Cheung, what are you saying in terms of the effect on people's lives when they have these symptoms?
So there's something called the post-COVID functional scale, and it goes from 0 with no effect on your function at all to 4, which means like someone needs to look after you. You can't do your activities of daily living. And so obviously those who are 3 and 4 should be seen. But, we have a very stretched healthcare system, not only in the tertiary, quaternary care centers like UHN, but also with primary care. I keep hearing from my primary care colleagues that they're so swamped because they're behind with their usual work. And so they're so swamped. So I have been really advocating for some self-management as well, because if those self-management strategies work, great. And we need to sort of get those strategies out to the public so that they know what to do as well.
And I know it's hard. Again, this is to both of you. I know it's hard with so many symptoms in terms of options, in terms of treatments, but can you give us a sense of what you both have seen working? And again, Dr. Cheung, let's start with you.
So one common symptom is fatigue. And the fatigue is not just like, oh, I have a hard day and long day and I'm tired. One physician in Quebec put it really well, Dr. Anne Barrow, and she said, it's kind of like a cell phone. And think of it as, if you only have a cell phone that has 10% charge or 15% charge, and you try to keep it on and not crash it so that you don't have to shut it off. And so it's going from that 100% charge on your cell phone to 10 to 15%. So that means patients need to prioritize what they do, needs to rest and pace themselves, and can do all those things sort of, yourself. You don't actually need to see someone to do that. And that's what we call sort of resting and pacing, and that helps for symptom management, that helps for fatigue as well. So that's one piece that we have found quite useful, and have to thank sort of the myalgia encephalitis and chronic fatigue syndrome community in terms of helping with sort of, at the beginning of the COVID pandemic, sharing what they have learned as well. And the second piece is because we know that this virus is neurotropic, so attacks the nerves and actually muscles as well. And so one thing that we found is that for people who are short of breath and, they would have done a chest x-ray or something else and everything is normal. Their doctor listened to them and it's normal. One thing that we've learned is that the respiratory muscles are weak. And so doing breathing exercises, that's another sort of thing that you can do as a patient without seeing anyone. And so those are some of the things that can help. And certainly there are medications for various symptom management as well. But I would say that we have not found a cure that target the root causes of long COVID.
Over to you, Dr. Rendely. What kind of treatment options do you typically employ over at Toronto Rehab?
Yeah, I think that was a good summary of some of the strategies that we're using. And I think it really is important to empower the patient with those self-management, self-efficacy strategies, because even if they do come to rehab, it's a time-limited program, and often patients can't even get in or don't qualify, or just, I agree, our healthcare system is overburdened. So knowing which resources and websites are high yield and provide really good, accurate, up-to-date information. There's some wonderful breathing exercise videos and patient resources that we can link to through this, and some that are done in over 60 languages that would capture some of the multiculturalism that we see here in Ontario. I think it's important to note that COVID as a virus was new, but we are using strategies that have been well researched and have very good evidence from other viruses and other types of rehab. So we borrowed fatigue management strategies from the MS community that have been well well researched. We're using some of the self-efficacy strategies from the chronic pain community and the chronic fatigue. We're borrowing from our stroke colleagues and some of the rehab. So I think at Toronto Rehab, we've done a really good job at bringing in our different colleagues from various other subspecialties within physiatry and within rehab and our rehab colleagues, and have been able to extrapolate it to this group that is the post-COVID patients. And some of it is working extremely well, and some of it is a little bit of trial and error with each patient being a little bit different. But just because COVID is new, the strategies that we're using, we know have worked in other forms of rehab. So it's not like we're starting from scratch with all of the different ways that we can help rebuild a patient back.
And Dr. Rendely, I know there's a bit of a silver lining here in terms of responses to long COVID. If you could mention or walk us through an innovation to accommodate infection prevention and control protocols at TRI, your virtual COVID-19 rehab program for post-COVID patients. Could you talk to us about what you and your team came up with there?
Yeah, so the UHN program that was screening PCR tests back from the emergency department in early 2020, March and April, noticed that there was a subset of patients who were not recovering as well as they should be, or as other patients were. So as early as May of 2020, they reached out to see, could we help rehab this group? And so there was no literature on what we now have learned to call post-COVID condition or long COVID. But we looked through the literature and tried to borrow different scales and things that we could use in order to kind of capture how we would treat this group. Took other therapists from the musculoskeletal program or the oncology program, and we created the interdisciplinary virtual COVID rehab program with our first patient coming through July of 2020. And so clinics were not open, and we had to pivot very quickly into virtual care. And I will credit Dr. Mark Bailey and the team at Toronto Rehab that was already looking into delivering rehab virtually, because we do get through UHN patients not just from the local area, but we have patients in Sudbury or that come to us from North Bay. And so how can we continue with continuity of care? And so the pandemic expedited that. And I'd say that's a silver lining for a lot of clinicians and a lot of patients, that we've been able to implement virtual care as part of the needs. But we found really good success that patients don't want to spend energy coming to an appointment, traveling to it, waiting in the waiting room, going through the therapy, transitioning back home. And so we're removing that barrier and then using their energy for the actual therapy, or to get them to do more during their day that is a necessity. And it's been quite phenomenal to see the success, and I think patients are quite pleased.
Dr. Cheung, I've read of cases where patients endure symptoms as long as 2 years, or as long as the pandemic has been going on. What do you tell patients about the timing for recovery from long COVID?
Everyone is different. So that's what I tell them. And the more that you can rest and pace yourself and not go through the roller coaster of feeling good, trying to go back to 100% of activities and then crashing. And that kind of roller coaster can keep going and can end up in a sort of not so good place. But if you actually cut that and try to keep under the threshold, whatever that threshold is, and everyone is a bit different in terms of, the threshold where will make you crash. And so if you can cut that, people do recover. And that's sort of one thing that's maybe different from the MECFS community, where once you get it, there are very, very few sort of people who recover. But now we're seeing this a lot earlier, because the average number of years that it takes to diagnose someone with MECFS has been 8 years. So we're seeing patients in the first 2 years, 3 years maybe, of sort of their illness, because COVID is fairly new. And so I'm hoping that by catching them a little bit earlier, that we have better outcomes in terms of improving and returning back to their usual activities.
And Dr. Cheung, do we know yet, is there research that's capturing what percentage of people who get long COVID fully clear it, or is there still those who have it 2.5 years later?
There are people who haven't 2.5 years later. However, we have seen many that have made a ton of improvement. They may not be back to 100%, but they are back to 85, 90% and working. So they've made big strides to sort of the initial sort of days of, struggling with even making coffee and making a meal, to being able to walk, a couple of blocks and sometimes even more. So I see patients improving.
And do we have a sense yet of what makes recovery so tricky in terms of clearing whatever the symptoms are? Because it makes it difficult to know when to go back to work, and it makes it, I guess, a bit scary for people thinking that this could go on forever.
Yeah, so I usually tell people, let's concentrate on the right now and deal with the right now without sort of like, thinking about the future. Like I tell them, you are not sort of fortune tellers. You don't really know how the future is going to be. So, and we are trying, like the medical community are trying to find solutions as well. Our research group is doing a platform trial, and other trials to try to see if we can improve the outcomes. So I think, every week, every day, we're having another piece of the puzzle. And so I would say that concentrate on right now, see how you can relieve those symptoms. Sometimes it's through these self-management strategies, but sometimes it does require a little bit of help from medications and other things as well. And I also tell patients that, think of it as a pot of energy and that everything dips into it, not just the physical part, because someone would tell me, I haven't gone running for, since I got COVID. What are you talking about? I'm already kind of a couch potato. Well, it's multiple things. It's the physical piece, is the cognitive piece, is also the emotional piece. So if someone actually have high anxiety, that actually taps into that pot of energy. And so, that definitely needs to be treated so that, you have more energy for other things.
I was going to say, Dr. Rendely, the mental wellness aspect here is another component, I imagine. What role does that play in recovery?
Yeah, that's a huge component. And I think on any initial screen, if a patient comes to you, it's important to check in with their mental health, not just from the virus itself, but the pandemic over time has been very hard on people. Isolation, giving up a lot of social activities or travel or things that people have enjoyed doing, and really having to recompartmentalize life in a totally different way. And now a whole new set of anxieties. Some people aren't ready to give up masks or go back in public or join back in where other people might be ready. So then there's another struggle with, I want to see these people, but I'm not at the same place they're at. So I think we always need to take into consideration where someone's at and how they're doing mentally. It's a huge part of recovery in general. And we know that patients that have had a major health diagnosis or change in their status because of a change to their health have a higher risk of having a change to their mental health as well. So we do screen anxiety, depression. If there's an underlying condition already or diagnosis, we want to make sure that it's still under control, and getting other mental health providers involved as needed. And then same sort of thing, going back to the self-efficacy, self-management skills. Sometimes from groups, we know that the COVID community or the post-COVID community has been very big in supporting each other. And some people might feel connected by that strength in numbers. So letting people be aware that they're not going through this alone. And some are okay to deal with their own social network, and others want to talk to people in a similar situation. So that same not one size fits all applies to this, but making sure that we're recognizing that through our clinic, about 30% of individuals are identifying as having a mental health component to their symptoms. So that is not insignificant.
Yeah. And further, Dr. Rendely, I've read reports where long COVID is referred to as the pain that can't be seen. When you read firsthand accounts, there's people who often say they don't feel heard or believed. Has that arisen as a factor in your practice?
There are some patients who have said, I've seen so many physicians, or I've gone through so many tests and everything comes back normal and I'm still feeling this way. And I think there's several ways that you can kind of approach that type of patient, and not just for long COVID, but similarly our post-concussion patients, or even patients with anxiety or depression where there's not a physical manifestation that can necessarily be seen. But there's reassurance that we're not missing something else, that they've been through other testing, and that we know that we're not missing another diagnosis that might have a different trajectory or path through the healthcare system. And that, well, some of this we can't fully explain. Patients come with a whole host of symptoms that physiologically we can't necessarily explain right now with some of the research we know, and maybe that'll change as it unfolds. But my job is to listen to the symptoms that they do have, hear how it's affecting them, their quality of life, their day-to-day, and see how we can help them cope with it or manage it or accommodate for it. And sometimes it's a reframing of how can we live with this, or how can we bring it down 10%, not 100%. So it depends what it is, but it is sometimes hard for these patients where they feel like they've been through the healthcare system and they're still fighting and suffering. And so hopefully patients do feel listened to. As providers, that's a big part of what we do.
Dr. Cheung, in your research, can you give us a sense of, if you get COVID, what are the odds of you getting long COVID?
It depends on who you are. So we do know that those who have had vaccinations have a lower risk of long COVID. Those who have more severe symptoms have a higher risk of long COVID. This is in the acute phase. We also know that women have a higher risk of long COVID, 3 times more than men, even though we do see long COVID in men as well. And in terms of the age group, we see it mostly in age 35 to 65. So it is the working population. These people have productive careers and other things. And so that's kind of what we're seeing in terms of risk. We also notice that obesity or increased BMI increase the risk of long COVID as well.
And we are more and more hearing news stories about COVID-19 having long-term effects on the heart and the brain. Do we know why that is?
Well, COVID-19 is really the SARS-CoV-2 virus, and that virus attacks the cells in our system through the ACE2 receptor. So that's a very specific receptor. But the problem is that this ACE2 receptor is everywhere. It's in your heart, it's in your brain, it's in the GI tract, it's in your kidneys, and is in your prostate. So that's why we're seeing so many different symptoms and affecting so many different organs as well.
This brings up the issue of the longer term impact on healthcare, which you've both touched on. I want to drill down a bit further here. Dr. Rendely, first with you. I know you've raised concerns about the demands of long COVID on the healthcare system. And if we do some quick math, say if we go with the estimate that say 20% of people who get the virus will get long COVID, and we know about 1.5 million Ontarians got COVID, so have had COVID so far, that's approximately 300,000 new patients in the healthcare system. Are we ready to accommodate this increase?
The short answer, no. I think the important part is that if we know vaccines can decrease your risks, if trying not to get COVID in the first place is the only preventative factor towards not getting long COVID, then how can we continue to implement the strategies that we know are going to be helpful? So I think on the silver lining side, we can still do things to minimize risk, even if we don't know all the factors yet as to why some do and why some don't get long COVID. There is some research being done that exercise is protective as well in minimizing the risk of severity of symptoms. And so meeting World Health Organization or Canadian Physical Activity guidelines for daily exercise or weekly exercise can decrease. So I think there are things to do so that you're not one of those people struggling. But I think we're going to need not just more clinics, because I agree with Dr. Cheung, we need to empower individuals to learn how to cope with some of these symptoms, but we need better knowledge translation skills and ways that we can reach the public so people understand what to do if they start getting symptoms, how to manage on their own initially, to implement strategies like pacing, prioritization, planning, positioning without needing the help of a provider, because most people don't have physiotherapy or occupational therapy covered. It's not part of our OHIP for most patients. So I think we have a long way to go in being able to accommodate. But I think things like this podcast, being able to send this around to individuals so those can feel empowered to know there are strategies, that this doesn't have to be a forever, is going to help us as a healthcare system mitigate this influx, because even though the peak of COVID might start to come down, this kind of tail that we're going to have is going to be quite long. And so I think we will see COVID rehab clinics for likely decades to come.
Wow. Dr. Cheung, you've said in the past, understanding long COVID or post-COVID condition is similar to the beginning of the HIV epidemic, when there were so many unknowns at the start of that disease as well. Any idea how long we're looking at then before we have more certainty about the condition of long COVID?
Things are going much faster than, 30 years ago at the beginning of HIV, right? So I am hopeful that we will learn a lot more. And every week, there's another piece of the puzzle, which is great. But I agree with Ali that, it's going to really make us rethink how to deliver healthcare. Because, you mentioned the 1.4, 1.5 million with COVID, that's the confirmed ones. So, that does not include everyone else, including myself, that got RAT tests, right? Like the rapid antigen home tests. And the estimate is actually probably like 60% of Ontarians, which is like 8.7 million people.
Right.
And even if you go very low, say 4 or 5% of that population, that's a huge number. And because COVID also affects the healthcare providers, because they're frontline, they're essential workers, there are many issues. So, we actually have people not well, can't work full time, been off sick or retire early, right? So there are all those sorts of issues as well. So I think we really need innovation in terms of how we deliver sort of patient education and how we sort of deliver care as well. And the Toronto Rehab Program that's virtual is one example of that.
Appreciate you both. I'm going to bring to a close my questions, and I want to bring in the audience questions because there's been a lot piling up since we've been talking. So if we want to throw those up, gang. First one from Walter. Does each repeat infection of COVID result in a higher risk of long COVID? Who wants to start us off there?
And I can start. So that's a great question. I would say that not having long COVID with your first infection doesn't mean that you can't get long COVID sort of in your subsequent infections. And often every COVID infection is a little bit different. Like I have patients who have had 4 infections and affected them totally differently. So it's a good idea to avoid COVID infection in general. Is it a direct kind of linear risk? The more times that you got COVID, the higher likelihood? I can't tell you. I don't know. We are cleaning data and looking at that issue, but I can't tell you whether that's true or not. But I just know that every COVID infection is a little bit different. If you actually had a COVID infection with lingering symptoms, it's highly likely that your second infection will make these lingering symptoms flare, and it will take you a little bit longer to get rid of them as well. That's what we are seeing.
Next question, what can be done about brain fog? Dr. Rendely, you want to start us off?
Sure. I think it depends on how it's affecting the patient. So is it attention? Is it memory? Is it concentration? There's lots of different strategies that can be implemented, making lists, using a planner, using timers, double checking, writing things down and confirming with other people. So it really depends on what is being affected. If it's in the workplace, it's really important to speak with a manager or someone to try and truncate, to have someone double check, to try and cut down on screen time or noise or whatever kind of triggers make other symptoms worse. So it's not often in isolation. And then to find out what those triggers are and how to minimize them, because brain fog often goes hand in hand with fatigue. So then using those strategies of the pacing and prioritization. So patients should be aware that they can try a multitude of strategies and then pick one or two that might work for them, or try one or two, and if they're not working, try something else. But it's about recognizing what's kind of causing it and trying to find a way to mitigate and work through it, and then making sure you're not overdoing it to cause it to linger longer.
Next question from Walter. A recent study of patients who had long COVID. Oh, no, we're going to go to Jennifer. All right. I've heard that it's wise to avoid intense exercise for a period of time after COVID infection to help prevent long COVID. Is this true? If so, for how long should one take it easy?
I can take that one. So it's true. So I usually tell people, depends on how they're feeling. If they're not feeling quite normal yet, don't go jogging. Don't go do a 10K marathon. I think you need to sort of back off a little bit. But if they are feeling okay, then it's okay to sort of start doing some stuff. Usually we talk about this as sort of the first 3 months. But for most patients, if they have recovered after the first month and they don't really have any residual lingering symptoms, then they can try to gradually pick things up physically and start doing some exercises and other things. But if someone actually has brain fog and other sort of long COVID symptoms, then I would suggest waiting and take it easy. Not to do nothing, but not to push themselves. So there is some data around that. And certainly that's what I'm seeing clinically as well.
Back to Walter.
Sure. I'm just going to add in, I think there's a large vocal community, but a small clinical community of individuals who truly get worse with exercise. So the post-exertional malaise diagnosis for people that are told to exercise and move that truly flare for 24, 48 hours following activity is not everyone. And so there are individuals that, like any viral illness, after you've been in bed sick for a little bit, you don't just go straight back to doing your gym routine, but you go for a walk and then maybe you increase your pace and then you build on that. And for most people, that's generally okay to really just follow your own body's lead. In the case that you truly flare, in the sense that your symptoms cause you to crash and end up in bed for the next 2 days because you've gone for a walk, that's a completely different story. And I think people have heard about individuals like that, and it's important to recognize, and not everyone can do the graded exercise, but some people can. And so it's not a one size fits all for all of these answers. And so if you've read something and you're concerned it might fit with you, it may not. And sometimes you can try on air, and sometimes it's important to seek guidance from a healthcare provider. So just want to throw that caveat in there as well.
Absolutely. All right, so back to Walter. A recent study of patients who had long COVID in Britain indicated that 100% of sufferers experienced microclots in blood. Can you speak to the risk associated with this? Dr. Cheung, would that be you?
Sure. The microclots, so clinically, what we're seeing is that in the first 3 months, we see actually not just microclots. We can see bigger clots, like clots that clog up your lung and you have trouble breathing, called pulmonary embolism. We see DVTs, deep vein thrombosis, clots in the legs. So not just micro, I would say they are fairly big, and we can see it with the usual tests. In terms of not being able to see it in the usual tests and have to have special tests to see if there are microclots. That issue, so there have been many things that have some data supporting it. So I look at that study as one piece of the puzzle. So it's also, this particular study thought, oh, maybe this is the explanation why people have long COVID. But I don't think that's the whole explanation, because patients have been put on aspirin, have been put on, other blood thinners, and they don't really feel better with from their long COVID symptoms. So I think this is one piece of the puzzle, but not the whole thing. There are other theories and data supporting it, like, perhaps there are these viral proteins or even residual virus that's in your body that's causing havoc. There are inflammatory things. It's an immune dysregulation with autoantibodies. And the lining of the blood cells, blood vessels called endothelium, maybe there's a dysfunction with that. And there's also data suggesting that mitochondria, so those are the powerhouses in cells, that there is a problem there too. So I think we really need to look at the whole literature and not sort of hang on to one study per se.
Back to Jennifer. I've read that long COVID is or can be an autoimmune response to the virus. Does that mean that people with existing autoimmune conditions are at greater risk of getting long COVID, given that people with autoimmune issue are likelier than average to have new autoimmune diseases diagnosed? Who wants to jump in there?
I can try to answer that. So there are people who have autoimmune conditions, and most of those patients are actually on immunosuppressive agents. And so are we seeing more long COVID in those on immunosuppressive agents? Not really. But like there are genetic predisposition to autoimmune conditions. And one thing we do learn about sort of long COVID is that there are certain genetic markers that have been identified. The toll-like receptor 7 protein and also MARC1, they're also a common variant that's been identified as well. So there may be some genetic predisposition to it, but this is early days, and I think we need to learn a bit more about that.
This next question is a great one for all of us. In addition to getting all recommended boosters, how can I prevent getting long haul COVID? Dr. Rendely, you sort of touched on this before. Do you want to go a little deeper here?
Sure. Yeah, I think the important part is to try and avoid COVID as much as possible. I still think masking and hand hygiene and trying to be as responsible as possible is going to be important. As I mentioned, some link to exercise and limiting the risk of severe infection. As mentioned in the question here, the booster shots and staying up to date with the vaccines as they continue to unfold is going to be very important. And then just general like healthy lifestyle habits. So trying to get enough sleep, staying on a regular routine, getting up and going to bed at the same time each day, keeping your body in good shape. Eating a regular healthy diet, minimizing excess sugars, excess alcohols, drug use, things of that nature, just making sure that if you do get the infection, that you're kind of as healthy as possible in order to fight it, and hopefully having less severe infection initially has some protective factor against long COVID. If you do already have long COVID, and we mentioned this earlier, trying to maximize the time between the next infection and not getting them so serially in order to increase your chance of recovery between.
Next question from JJ. What tests can one get to determine if one has ever gotten COVID-19, especially since it can be non-symptomatic? Can tests determine how many times and when one has gotten COVID-19? Also, can tests determine if the COVID-19 has become or could become long-haul COVID?
So maybe I'll take a stab at this one.
Please, yeah.
I wouldn't go testing if they're not symptomatic. It's possible, although I don't know how available it is, to test if someone had a COVID infection before, but you can't tell how many times they have had it before. And the test is also not the most sensitive either. So the test is actually the antibody test to not the spike protein, because the spike protein you can get from vaccination as well, but to something called nucleocapsid, which is sort of the envelope of the virus. But we know that people don't develop antibodies to nucleocapsid as well as to spike, and it doesn't last as long. So, testing negative to that doesn't mean that you haven't had it. So, I know it's a very sort of convoluted answer, but bottom line is, one, I'm not sure that you should test. And two, other than the nucleocapsid antibody test, the other tests are not very good.
This next question is a great question, actually. Was Delta more likely to cause long COVID than Omicron? And are we going to have to wait a year since January of 2022 to see the true extent of long COVID from Omicron infections?
So in general, Delta is more likely to cause long COVID than Omicron. So based on a UK study published in Lancet, if Delta is 10.8% of people with Delta have long COVID, then it's 4.5% for Omicron. Now, what we haven't quite sort of, looked at is actually these people often already had 3 doses of vaccination before they got Omicron. So how much is sort of because of the vaccination and how much is because of the different variants? And plus, there may be future variants because we know Omicron is much more infectious. And the other issue is that there's so many more people over the last, 6 months, a year, who got COVID than compared to prior. And so even if a smaller percentage of, the current people, it's still a large absolute number.
Next question. In your opinion, what are the top 3 websites in Canada for healthcare providers re-education about long COVID assessment and treatment? What about the USA or UK? What's missing? And I'm not going to read out that URL, but I'll let you two jump in with recommended websites for long COVID assessment.
Yeah, there's some great work that's been done across Canada and elsewhere. I'd say the Ottawa Hospital recently put out, I believe it was February 2022, a patient self-efficacy, self-management website that's very user-friendly. That's available free of charge, which has some great resources. Alberta Health Services has put together a very well done website. They have videos, they have blog posts, they have podcasts for patients, but also for providers. So it depends who you're targeting. Long COVID Physio, I believe, is out of the UK and has resources available in over 60 languages. The World Health Organization has really great, easy to follow patient handouts as well. So there are some really well done education options, and I'm happy to provide those links to you, and you can post it with this recording as well. Because instead of reinventing the wheel, I think we should really capitalize on the great work that has been done. I know Dr. Cheung's group through CanCog also has a great breathing exercise video that patients can use and follow along. So I think it's just about knowing where to go, and part of our job as providers in the long COVID sphere is to help point people in the right direction.
Well, then I'll throw the next question to Dr. Cheung, since you set it up for me, Alexandra. Are there any medications or exercises to help improve the difficulty with breathing? Dr. Cheung?
So doing breathing exercises do help. It really does two different things. One is strengthening the breathing muscles. So that's the intercostal muscles in between your ribs that lift your rib cage up, and also the diaphragm. So those are two big pieces of muscle at the bottom of your lungs. And when you contract them, you pull it down. And so it's through this sort of lifting of your rib cage and pulling the diaphragm down that sort of that's the lungs sort of expand, right? And so and what we find is that whether it's a neurological issue, like an autonomic thing, or whether it's the muscle weakness issue, retraining this is really important and will help with the shortness of breath. The second thing is that even doing breathing exercises, such as in Qigong or in yoga is pranayama, those are actually good for modulating your autonomic system as well. And so I think those are things that will improve the difficulty with breathing. And obviously, you know, if after doing those things you still have trouble, then you should be assessed by the physician to see why. Is it because of, you know, are you wheezing? Do you have, you know, bronchospasm, which we can easily treat? Or is it another issue? But most patients who are not hospitalized and have this kind of issue, difficulty with breathing, it's mainly a restrictive lung issue. So we see people not taking deep breaths regularly. And so we can sort of, I do suggest sort of using breathing exercises.
I'm going to ask Dr. Rendely, would you have anything to add to that over at rehab?
No, I think that's a great explanation. And I think there's different styles of breathing techniques. So some patients say it's hard for me to meditate or lie there and focus on my breath. And there's some more active ways of doing it. There's box breathing and 4 counts and things like that. So I'd always say if one thing doesn't work for you, that doesn't mean all breathing exercises won't. And you have to be okay with a little bit of trial and error, and also kind of trusting the process. Doing it once or twice and saying it didn't work isn't necessarily a fair shot. So really giving it some time to implement, to work on your technique, and then seeing how that goes over maybe like a 2-week period before you've kind of given it a real try.
Next question. Does the rebound viral replication in patients who take Paxlovid put a person at higher risk for long COVID than if they just cleared the virus on their own? Less total 2 days with rapid antigen test positive without rebound occurring. Who can I throw that question at?
I can tell you what I don't know. What I can say is that this story of someone taking Paxlovid and after stopping Paxlovid seemed to get a return of symptoms is quite common. I have heard it many times. And whether that puts someone at risk of long COVID, I can't tell you. We don't have a lot of data on that, but would certainly be interested in sort of following up on some of the longer term data from the Paxlovid trials, right? So I think there's a way to look at it, but I can't tell you the answer to that. If someone actually, Paxlovid is recommended for certain people, so not everyone. And those tend to be sort of who are older in age, or have immunocompromise, sort of these immunosuppression. And so there are certain risk factors. It's posted on ontario.ca as well. So you can certainly go on that website and see whether you qualify for it, right? If you qualify and is at higher risk, and we're talking about really high risk of hospitalization. And so I think it's better not to be hospitalized if you can avoid it. So then you should go ahead and take the Paxlovid because that has been shown to help. But if you actually are someone that doesn't qualify under those risk factors, then maybe you should see whether you can get rid of it yourself. And I think I can't tell you the exact answer to this particular question, but I hear it quite often, actually.
Next question. Is there evidence that long COVID symptoms can include hearing loss and or tinnitus? Thank you. Have either of you heard of that?
Yes. Tinnitus and hearing loss is something that we have seen.
And is there anything in terms of treatments or rehab for that particular affliction?
Tinnitus is a little bit tricky, but there are sort of some things that may be possible. And anecdotally, sort of I know someone who got tinnitus and hearing loss. It's unclear whether it's from Paxlovid or whether it's from long COVID. And that person, because qualified for sort of some hyperbaric oxygen, actually got some and recover from that. Now, whether that's just because of the timing and that person recovered, I can't tell you, but I can tell you that the tinnitus and hearing loss that I have seen tend to improve over time.
Next question. Not everyone has a PCR diagnosis because of testing access, but most programs, clinics require it. In addition, some clinicians do not believe in long COVID. How can people who are suffering with serious disability access the rehab services they need? And please provide contact info for options in GTA.
I think most clinics recognize how challenging it was to get a PCR test back in early March, April 2020, and then again when guidelines changed in December 2021. And that's speaking to my experience here in Ontario. So with our UHN clinic and several of the other clinics that I'm aware of, it's a presumed or confirmed diagnosis. So I'm not sure if this individual had a clinic that was different from that, but I do think most clinicians do recognize that there are a subset of patients that are going to have lingering symptoms, and a confirmed at-home rapid test or a confirmed proximity to patient are really just symptoms that align with the timing of COVID and fit the general definition. Could benefit from the strategies that we provide to patients. As we mentioned, long COVID is a clinical diagnosis anyway. And there are websites, I believe it's the Rehab Care Alliance has a list of contacts for all the GTA location long COVID clinics that are available and their referral criteria. Often you do require a referral from either a family physician or a specialized healthcare provider, but some you can self-refer to some of their self-management groups. And most of the clinics also have websites that link to some of their online or self-management resources. So I think more and more hospital centers are linking patients to the appropriate resources. And I think that's something that's going to continue to occur. Even if someone doesn't have a formal PCR diagnosis, they'd be able to benefit.
I'm going to move down to Andrea's question. Is there a correlation between gastrointestinal issues post-COVID and long COVID symptoms?
I think that goes back to what Dr. Cheung was saying, in that patients are presenting with widespread symptoms that can affect the entire body. And some individuals are having GI symptoms and some aren't. A correlation between GI issues specifically and long COVID, every patient is different and may or may not present with ongoing symptoms just because they had GI as part of their primary infection.
Yeah, and I was going to add that in terms of the GI symptoms, it's also quite variable. Some people, like the question that's up front, have difficulty with swallowing. Some people have difficulty with sort of the movement, motility of the gut. Some people have constipation, some people have diarrhea, some people have cramps. And so they are quite different in terms of the symptoms. And yes, difficulty swallowing can be associated with long COVID.
And that has brought us to the end of today's questions. I want to thank our audience today for some terrific questions. Thank you for joining us. And to our experts today, Dr. Angela Cheung, clinician and senior scientist at UHN's Toronto General Hospital Research Institute, and Dr. Alexandra Rendely, staff physician in physical medicine and rehabilitation at UHN's Toronto Rehabilitation Institute. Thanks so much to the two of you for joining us and taking time out of your busy day to share your insights and expertise.
Thank you. Thank you for having us.
Thanks so much.
This live stream is available for viewing at the UHN Foundation Facebook and YouTube page. And finally, donor support. Your dollars fuel the groundbreaking research initiatives of our award-winning UHN scientists who are working every day to discover new treatments and cures for patients. Pioneering work that actually, you should know, Newsweek magazine used to rate Toronto General Hospital the 4th best hospital in the world in 2022. And that's the 3rd year in a row it's received that honor. So if you're able to give, we ask you to consider making a donation. Go to www.uhnfoundation, that's all one word, uhnfoundation.ca/help. Thanks for tuning in. We'll be back soon with another COVID-19 live stream. Keep an eye on your email inbox for details. In the meantime, be kind to each other, get vaccinated or get your boosters, and stay safe, everyone.